energetic advocacy. Thank you.
Thank you, Anne, for another fantastic example of the biosocial complexity of what we're trying to address at the center. It gives me great pleasure now to call upon Dr. Lubna Samad, who is a consultant pediatric surgeon at Indus Hospital in Karachi, Pakistan. For those of you that don't know, Indus Hospital is a world-class, state-of-the-art facility that provides free medical care to those who are sick and poor. It's truly an incredible, incredible place. And Dr. Samad is the chair of the Indus Hospital Research Center and represents the Indus Hospital Center for Global Surgery on the executive committee of the G4 Alliance, which sounds something like the G8 and the G20, but it's actually a group committed to increasing access to surgical care globally. She's also a lecturer in our department at Harvard Medical School, and she's a lecturer at the Center for Global Health Delivery here in Dubai. She's been a great proponent for ensuring that the socially disadvantaged receive the highest and most dignified standard of care. She is literally a tireless worker and a true biosocial practitioner. She goes from performing surgeries, I think on Tuesdays and Fridays, because I'm always calling her at the wrong time, to ensuring that poor patients have enough food to eat when they're at home. So her work and passion has been an inspiration to me and the many others who have been working with her. So I'm really thrilled that she's here to talk to us about global surgery. Lubna.
What am I using this? This one? Okay, great. Ladies and gentlemen, I'm delighted to be here today. For some of you who have seen the center today at its launch, I think what you don't realize is the amount of effort that has gotten us to where we are today. And I've learned a lot of things from Salman in all the years I've known him. But perseverance has to top that list. So on behalf of the Indus Hospital and Interactive Research and Development, both groups are well represented here today. I would like to congratulate Jennifer Puccetti. She's the most remarkable woman who has really helped materialize a lot of the dreams that Salman started off with many years ago. And to congratulate Mercedes and Salman and their son Zain, who I have always thought of as the mascot for this center. I hope he's watching it on live stream, Mercy. It's morning in Boston. So I feel that we're all here today as advocates for our own specialties. And we've thrown a lot of numbers on the enormity of the problems that we are all facing in our day-to-day lives. And I think perhaps that's what is important for any center to flourish. It has to have people who are passionate about what they are doing, people who are in contact with their patients because they see the suffering on a day-to-day basis. It's not an academic exercise. It hurts them daily. And I think it's also important that we have a commitment to research because we believe that the answers that will help us in finding the most effective solutions in our own settings will come through systematic research. A lot of people in this room are committed to that combination of three things, and that is essential, I believe. So when we talk about global surgery, again, I'm going to throw numbers at you which describe the enormity of the problem, first of all. 5 billion people, that's 2/3 of the population globally today, do not have access to safe surgical care and anesthesia where they are when they need it. Similarly, at present, 313 million surgical procedures are conducted annually, but only 6% of these procedures are taking place in the world's poorest countries, where 1/3 of the population lives. So there is clearly a huge unmet need in lower and middle income countries just to achieve the bare minimum of emergency and essential surgical procedures. We need to ramp up and add an additional 143 million procedures annually to the table, literally, to the operating table. Now, this figure of 6% of procedures being given to a third of the world's population is something that we're very passionate about at the Indus Hospital, because it addresses our core belief that equity must be there in healthcare. And I know it resonates with our partners and our friends in Boston as well. And that's really why global surgical care has been gathering momentum in the past decade or so. So I tried to define global surgery because people think that public health is here in one corner and surgical care is another thing. Where do you bring it together? And the hands on this picture belong to some of the surgeons in the room who are clearly happy to see themselves up here. But essentially, I'm going to use a definition that has been put forward in a recent editorial by the World Journal of Surgery that is a little longer, but I think it addresses the core components of global surgical care very nicely. It has to address a condition that has a very large health burden. There have to be surgical procedures or other interventions that would be able to address this burden. It has to be cost effective, and it has to be feasible to promote globally. So these four components really sum up those procedures that merit a place in the list of global surgical procedures. Now, the gathering momentum really came to a head in the past year when this was a banner year for global surgery, literally, with three major milestones being achieved. First of all, there was the DCP-3, the Lancet Commission that some of you in this room are familiar with, and then the World Health Assembly resolution that was passed in May this year. So talking about the disease control priorities, they published their first dedicated volume on surgical care, I think this was last year, showing that essential surgical care can avert 1.5 million deaths annually. Now, this does not include morbidity. It does not include impacts on quality of life. It does not include disability. Just 1.5 million deaths annually avertable by surgical care alone. This was the effort of multiple people involved at many levels. And they've defined 44 procedures that meet the criteria of a global surgical procedure. And 2/3 of those, I think it's 28 procedures, are those that can be performed safely, easily in a district headquarter hospital. So the importance of taking surgery out of a super specialized milieu into the communities, closer to people's home, is clearly very important. And the most important thing to realize is that this is not expensive. Surgical care is expensive for an individual who has to pay out of pocket. But as a societal commitment, it is not expensive at all. The tallies here show that it is well within the range of interventions like EPI or bed nets for malaria prevention that we take as granted in the public health world. So that label of, or the mindset that tells us that surgical care is equal to an expensive care is not real or believed anymore. Again, I think it was early February this year, the Lancet Commission published its recommendations on global surgery. And this exhaustive procedure over 2 years involved 25 commissioners, 110 countries were collaborated, 6 core indicators were developed, and there were 5 key messages that came out of this commission. And if we look at the simplicity of these 6 indicators, I really like them for the fact that they reflect how prepared a facility needs to be. So a simple 2-hour access. So for me, 2-hour access is a flight to Karachi. But for somebody who lives down the road, getting from a poor slum area of Karachi in the middle of the night or during a strike call to the hospital, Indus Hospital is right down the street, it's providing free care, but are you able to get there in time? And this 2-hour cutoff was used for obstetrical emergencies as the benchmark. And then we're looking at the ratio of, the availability of specialist surgeons, anesthetists and obstetricians per 100,000 population. A very simple benchmark that can be collected rather easily in many countries, including in the developing world. And then we talk about, once a patient does reach a facility, the delivery of healthcare. How much procedures can that hospital perform? And how safely can they perform it? And the perioperative mortality rate reflects how safe that hospital is. It's not enough to go up in your volume. Surgical care has to be safely provided. And then we measure impact in how many of the population are protected against an impoverishing or a catastrophic expenditure. Again, these are all ways of making sure that surgical care is not only provided, but it is provided in such a way that it does not make a family destitute. It should not make a family go out in the street because they've had to take out money to pay for surgical care. Most people wouldn't be able to afford it in any case at all. The third milestone achieved this year was the World Health Assembly Resolution 68.15. This was the first resolution that the World Health Assembly has passed, which addresses surgical care specifically and asks for strengthening of emergency and essential surgical care and anesthesia as a component of universal health coverage. So the term universal surgical coverage is now being used with increasing frequency. But the real challenge lies that how do you take a policy created and written up in the World Health Organization, in nice auditoriums like this, to the reality that faces us in the streets of Bangladesh or Jakarta or Karachi or many of the places where all of us work? And that is why the center is so important to us. It helps us bridge from policy to practice on the ground. How to make these policies actionable is what we hope the center will help us to achieve. The G4 Alliance, which was instrumental in getting the World Health Assembly resolution on the floor, has been working to bring together a number of organizations to promote advocacy on a common platform and make a global push. So as of earlier this week, the number went up to 54 member organizations representing over 350 now, representing organizations spread over 140 countries. And the idea is to give global surgery a unified voice across the world. So what are the key objectives for global surgery? We need to have national surgical plans in place. We need to have indicators that are measurable, very similar to what the Lancet Commission has proposed. Financial transparency, donor downwards, needs to be very much over there, and financial risk protection is important. And I would like to mention here that these four points really come from Dr. John Mehra and his excellent summarization of what he believes is the way to go forward as he concluded the first 2 years of the Lancet Commission work. So the Lancet Commission advocates that there should be has put together a template, a suggestion for what a national surgical plan should look like. And it recommends that governments use these ideas to help strengthen their delivery of surgical services. Now, these 5 pillars, so to speak, are not the only ones that are important, but we believe that they are core and have a key role in every country, and additional factors may be important in different settings. The fascinating thing is that when I read this particular 5 components, I realized that we had been practicing each one of these for the past almost 10 years at the Indus Hospital. And that is where we work in Karachi. The Indus Hospital provides quality care. It is free of cost, which is important to us. We looked at the first 5 years of operations at the Indus Hospital, from when it started in 2007 to 2012. And we documented that over 40,000 patients have been treated here, of which 84% are surgical patients, because these are the ones that hit the people most. It's difficult. It's easy to go across the road and get diarrhea treatment. People do a one-off pill for diabetes and hope it will get cured. But when it is surgical care, they need a facility, and that is why the Indus Hospital has focused primarily on surgery as its initial strength. Surgical procedures increased fivefold in these 5 years, and bed occupancy increased. I think we are privileged to be in a country where 98% of all donations, because this is completely philanthropic funded, so a total of 98% of 26 million US dollars was generated locally. So not only do we believe it's a model that works, we believe it's locally sustainable, and that is very important for the long haul. Indus Hospital is planning, this is certainly more than hope. In 2013, we were 150 beds. We've already reached in excess of 400 beds, and we are going to go up by tenfold, inshallah, by 2018. So 3 years and a long way to go. And our operational budget will increase tenfold during this time, with a projected $100 million US dollars by the end of this phase of expansion. We're geographically going to be spread across many parts of Pakistan, where populations are dense and where the need is highest. The Center for Global Surgery at the Indus Hospital looks to complement the service delivery component with research, which is focused on bridging health delivery gaps and improving the quality of care that we can provide to our patients. And that is where we find that we have such a close synergy with what the center here in Dubai is hoping to achieve. Examples of our work include the Clubfoot program that we have now, we've completed 4 years of this program with over 800 feet treated and enrolled completely free of cost. Not only was it completely free of cost, we provide bus fare to families to come in because it requires regular visits, and just the bus fare is a burden on many of our patients. And then we have a mobile app that links us to the International Clubfoot Registry so that all our treatment is recorded, it's transparent, and it is available on a website for everyone to monitor. The first Do No Harm project was aimed at improving patient safety, done in collaboration with the Johns Hopkins University. And in this, we have looked at how we can improve patient safety through real-time monitoring, ensuring that there are checklists, but more important than that, how we can change the mindsets of our healthcare professionals to keep patient safety and patient outcomes as the driving force for all the work that we do. Currently, we're working with the center on a surgical site infection surveillance project where we're going to have patients involved in monitoring their own surgical site infections. Some patients require as much as a 1-year monitoring, and how to do it using a mobile health app mechanism so that they can come in when they need to. And the other project that we're currently working with the Children's Hospital in Boston and Dr. John Mera's team is to ensure that our patients get value in their care. So not only is it important that the outcomes are of a good quality, of a high standard, but that we do that with the best possible cost efficiencies. And again, I want to bring up a point that was earlier discussed today in one of the talks in the first half, that one of the reasons why we've enjoyed working with the center so much is that it's not only important to have equity in the health care you provide, it's also important to have equitable partnerships. So we believe in partnerships that are sustainable. We do not believe in parachute missions. And we believe that being here for the long haul means a presence here, collaborations that can build capacity in our own healthcare professionals, and thus make this a sustainable aim. I'm going to end with the project that, as a pediatric surgeon, is closest to my heart. Circumcisions have been around for a long time. They're on an Egyptian relief in the tombs of Saqqara, 5,000 years old. Jews and Muslims have been practicing it as a compulsory societal ritual. This picture is from the Ottoman courts, miniature paintings done, showing the gentleman in the first picture with the white turban in the center on the horse is the Surgeon General. And the boys being led, one would like to say a bit forcibly, to the circumcision pavilion are the princes of the Ottoman times, being taken in about the age of 10, 11 years for circumcision. Now, the proportion of males being circumcised worldwide is about a third of all males worldwide are being circumcised or are circumcised at present. This number is expected to grow with the increasing evidence linking HIV transmission and circumcisions. Where we're located as a center is really the hub. A lot of our countries that we are that constitute the region of the center are high prevalence circumcision areas. What we're looking at is 20 to 25 million newborn boys annually will be requiring a circumcision. And I can personally say that I have seen babies die of botched circumcisions. So for something that has been around for a few thousand years, that needs a scale of 20 to 25 million procedures on an annual basis, to have children die because we can't get that little bit of a science right just isn't right. The program that we are proposing, we're in the stages of starting at the Indus Hospital, is to have healthcare providers involved in performing safe, sterile circumcisions, because don't forget, this is also a great mechanism of spreading your hepatitis C, your hepatitis B, and HIV if it isn't done in a sterile way. To raise community awareness, creating a demand for the right kind of circumcisions for their own children. These are just examples of the kind of work that we are doing at the Indus Hospital, and we hope to be able to extend this expertise to other areas in the region, because we believe that surgery is an indivisible, indispensable part of healthcare. Thank you very much.
Thank you very much, Lubna, for a really insightful discussion about surgery. Really one of the biggest gaps that we're facing, and I think we're seeing here, you look at mental health, you look at surgery, you look at diseases like tuberculosis, we see, and you look at diabetes, these are all biologically complex, socially complex, and diseases that have been neglected in their own way. So it's a particularly distinct honor for me at this point to introduce my friend and mentor and colleague, Dr. Paul Farmer, who will talk to us about global health in the 21st century. Paul Farmer is the Kolokotronis University Professor at Harvard University. He's the chair of the Department of Global Health and Social Medicine at Harvard Medical School. He's also chief of the Division of Global Health Equity at Brigham and Women's Hospital in Boston, and the co-founder of Partners in Health, the Boston-based nonprofit that I'd mentioned earlier that has really defined a lot of our work. He serves as well as the UN Special Advisor to the Secretary General on Community-Based Medicine and Lessons from Haiti. And through his work in Haiti, Peru, Russia, Rwanda, and many other places, Dr. Farmer has successfully pioneered how to ensure that healthcare reaches those who need it the most. He's both a practitioner of global health equity and one of the world's great scholars on the subject, as many of you know. I think we could safely say that there are very few people in the world whose work has touched and transformed so many lives. We're all indebted to him for his passion, selflessness, and unparalleled commitment to ensuring that the weakest among us receive the dignified care that they deserve. So I know you will be as inspired as I am by this great man. Thank you, Paul.
Thank you. Thank you very much. It's so wonderful to be back here, and also to know that there are other people watching from well beyond. A year ago today, I was I was thinking about this when Zuru was speaking. The height of the Ebola epidemic was playing out in Sierra Leone, Liberia, and Guinea. I was on my way back to Boston and then here to Dubai for the Lancet Surgery Commission. The second of those three meetings had been held in Freetown and Sierra Leone, and it was already clear that Ebola was going to spread west, and in fact was likely already in the city of Freetown. It had never been in the city, perhaps, if that was the claim made, not entirely sure. And two of the people who were in attendance, today I was looking with one of the young surgeons for a slide for this presentation, and saw a picture of one of the young surgeons, 41 years old. There were probably only 5 or 6 surgeons left in Sierra Leone. And a year ago today, he was just beginning to fall ill and would die shortly thereafter, right before I came back to Dubai. And another thing that was happening a year ago today, it wasn't entirely clear where one would go back into the United States from Sierra Leone or Guinea. On that day, I believe, an American nurse had been detained by the governor of New Jersey and was in a tent. I was only Royal Air Maroc was still flying, and I found myself in Casablanca and on my way to Marrakesh for a brief medical meeting, and wasn't entirely clear how I would get back in. A friend of mine was in a very high-ranking U.S. government position. I won't name him, but I called him on the phone and said, "What is going to happen? I do not wish to be detained in a New Jersey tent." And I said that with some heat. Now, he thought it was a splendid idea, because then if I were detained, he said, "I will bring you a birthday cake, and you will make it clear that the state of New Jersey's policy is quite silly." I declined to do that and stayed in Marrakesh, and then headed back here to Dubai. And in that year, I've seen not only another train go up across the street, the center be completed and furnished, not just with beautiful furnishings that match this auditorium and the rest of this building, but with intellectual furnishings and trappings that will ensure, with the birth of a new university here, that global health delivery, critical studies of global health delivery will emerge from this place. I think there's no doubt, and the reasons have already been beautifully laid out in the course of the day. And it's just an honor to be part of this, and to be part, for me, for the first time, of this part of the world, and meet people whose work I have long admired, or in the case of our colleagues from Pakistan, just see them again, and think about all that will happen in the coming decades here, or in this hub that reaches to so many places in the world. A lot of what I was going to say is not really necessary to say, because it's already been elaborated. When we're speaking about delivery, we're talking about how we take the fruits of discovery science, which is largely basic science, much of it conducted in laboratories, that process that leads from discovery science through development of tools. And the tools may be preventives, like vaccines, diagnostics, like the one Zarir Udwadia mentioned, that identify a mutation or set of mutations that confer resistance to certain antibiotics, or it can be a therapeutic, a treatment, a surgical intervention, a chemotherapeutic or agent or antibiotic. All along the way, there are barriers, of course, but the barrier to effective delivery has really not been well studied in academic medicine or anywhere else. It's really in the last couple of decades, as has been mentioned, that we've paid attention to it. And without a focus on delivery, again, as has been said today, we will not be able to deliver care that can alter outcomes. Now, sometimes when Zarir talks, first of all, I feel very emotional, because I think about the patients that we see together with this horrible affliction that it is, of course, also infecting others. And the weight of the burden of that illness and so many others. Infants dying of botched circumcision all the way back, major mental illness without care, untreated surgical disease in general. Having worked on a number of these projects indirectly, there is a sense of weight and gloom that creeps into our discussions. The problems are just so enormous. But just identifying the problems as enormous, that is, having some sense of measuring them in scale, is important. And we have seen progress in this forward march from discovery to delivery that I'd like to review, starting with, I'm going to